Hi there. This is Sarah
Feel you can come on board. Sarah, welcome.
Hi. Thank you.
Go for it, Sarah.
Right, I'm going to let Ivan introduce himself because his name has already been shared with all the participants. And he's the one who initiated with us this call. So.
Good afternoon, everybody. I'm Ivan Ivanov, and I'm the team leader of the WHO Occupational and Workplace Health Program. And thanks a lot to Joe and Sabir for connecting with WHO and the use of your invitation actually to pulling together the other colleagues from WHO who are dealing with the different aspects of the outbreak of the coronavirus, so you can get a good update and ideas on how you can get prepared.
Thank you, Ivan. Good afternoon or good morning, everybody. My name is Sarah Hess. I work in WHO headquarters in the Health Emergencies Program. For this particular response, I'm working in the risk communication stream. And I'm going to give you a little brief update on the EPI situation, where we're at the moment. And then I'm going to hand over to my colleagues who I have in the room with me, who are the specific focal points for different areas in terms of infection prevention and control and clinical management. So in terms of the update, we have a total number of confirmed cases globally that exceeds 90,000. Approximately 80,000 of these cases are in China. The remainder are outside of China. We have over 3,100 deaths. And of these, approximately 170 are outside of China. So the number of cases, confirmed cases in China has been steadily decreasing. Yesterday, I think only about 130 new confirmed cases in China were reported. This represents the lowest daily case count since the 20th of January in China, which implies that China's massive containment efforts have definitely worked to slow the spread of the virus. I think of more concern at the moment for WHO is the spread of COVID-19 in countries outside of China. So I think we have about 72 countries outside of China that have reported cases. And these countries are in all continents, I think, except Antarctica. However, and most importantly, the vast majority of the cases outside of China are coming from three large epidemics in the Republic of Korea, the Islamic Republic of Iran, and in Italy. WHO, I think, still firmly believes that containment is possible in all settings, as has been displayed by China, and is currently underway in places like Korea and Iran and Italy. Our Director General has been very clear that the measures taken now by countries to prepare for possible scenarios will determine the course of the outbreak. And some of these scenarios have been outlined, and something our Director General is calling the 3 C's scenarios. And this is something to guide the level of preparedness within countries. The first C is to prepare for cases, to prepare for the first set of cases. The second C is to prepare for the first cluster. And the third C is to prepare for community transmission. And WHO is working with countries along the lines of these strategies to ensure that countries have the best support and actions in place to prepare for these scenarios. I'm going to turn over now to my colleague April Bowler, who is our infection prevention and control expert. She is going to give us an update from this perspective.
So thank you, Sarah, and I don't know if it's good morning, good afternoon, or good evening to all. My name is April Bowler, and yes, I work here with the big team. So I think that there's a few key messages from our side that we'd like to share with all of you, being frontline healthcare workers and basically if not frontline healthcare workers involved in the policies and strategies. So the first and most important message is that based on the current evidence that we have now, and also from the mission that was in China, the mode of transmission for COVID-19 is mainly through droplets and then contacts from fomites. There are certain situations where you have aerosol transmission, which is basically with aerosol generating procedures such as intubation, bronchoscopy, etc. But this is critical for prevention because this is basically what defines what are the strategies to put in place with respect to prevention. So I'm going to go through a few different things, but I think from the perspective of preparedness for the countries that don't have cases yet, one of the top priorities is that countries should actually have a national IPC program in place. For countries that do have this and that know the programs, they know that there's 8 core components that should be in place. For countries that may not have implemented or established this yet, the important thing is to really look at those guidance. You can find those on the WHO website. We can also share that after the call. But I think critically, getting into the mode of readiness would say that it's important at a national level for coordination to establish an IPC task force. This would be led by the Ministry of Health and obviously with all the different organizations and key stakeholders within IPC to start to look at how to really prepare the health system in collaboration with the clinical management teams as far as referral systems, what would be, for example, in some countries like China, they have put up fever clinics. So this is more of a systems issue. I won't go into the details of that, but just to highlight that on a kind of strategic level. Now, as far as actual different guidances with what are out there, you'll see, if it hasn't already been shared, on the website for WHO, there's some key products with relationship to IPC that are available. And I'll just walk through those. The first one is around what are the measures that should be used and put in place at the facility level for managing suspect and confirmed cases. Then we also have a guidance around home care for mild cases. And there is also something specifically on the rational use of PPE and then on the use of masks. So I won't go into, there's also an FAQ where there's a lot of different questions that have come in that is looking at questions around like disinfection, what do you use, how do you manage dead bodies? So we encourage you to go to that site because we don't have time to go through all of them. But I think a key message out of all of this is one of the major concerns for all healthcare workers and obviously also for WHO is the safety of healthcare workers. So with this, really what we're saying is that there are certain PPEs that should be used when having direct contact with patients. And these PPE, based on the mode of transmission of contacted droplets, is your medical mask or surgical mask, as some people call it, your gloves, your gowns, and basically eye protection, which can be a face shield or goggles. Now, if you're not having direct contact with patients, then the situation changes. There's a very big discussion going on with respect to do we use medical mask or N95 mask. So N95 masks are used specifically when there's airborne transmission. So these should be used either when you are doing a procedure which generates airborne, or if you're in an intensive care unit. Those are the specific requirements. But if you look, I encourage everyone to look at the rational use of PPE document. This document explains what type of PPE should be used in what setting. So it gives both settings for within the facility and within the community. Just one final point is around, we also have, it's going to be hopefully uploaded today, for if and when there are cases, healthcare workers have been exposed, and a tool to really categorize the risk of the healthcare worker and then how to manage that healthcare worker. And just to finally end on a note, there are trainings. On the open WHO, an introduction to IPC, which has 4 modules. So we'll encourage, as part of the preparedness for everyone, to really go and do those. It's very popular, and I'm sure will be helpful. I think on that note, I will stop for now, and any questions are welcome. Thank you.
So, what is the passage?
I think we're going to...
there was one question that has been shared by someone on the group. Yes.
Can I suggest, Joy, that we take questions at the end?
That was shared in the group. How long does the
virus survive?
Joy, can I suggest that you leave the questions for the last?
It's okay.
Yeah.
Sarah,
So maybe just about the fall mites. So
I think if the WHO team...
we can
can I
just
suggest,
answer that
Sarah,
one.
that we go through all the speakers and leave... Okay, if you want to go through that one question, but let's keep questions, I'll collate them. We take them at the end.
Okay, we'll answer that one question. And
So
then
the one question
Go for
is...
it, Sarah, to answer that one question.
Yeah, so we have evidence from other coronaviruses, not for COVID specifically, but it can be anywhere from a few hours, and the maximum is 9 days. There is a document now which has been uploaded as well, which is the water, sanitation, hygiene. It looks at some of those areas. The important thing about fall mites is that this coronavirus is an envelope and it responds well to your basic disinfection. So whether it's 70% alcohol or 0.5% chlorine. So from other experiences, it's your standard disinfections that can be used. Over.
Thanks, April. So I'm now going to hand over to Tom Fletcher, who is working on our team in the area of clinical management. Tom, over to you.
Hi, thanks very much. It's great to be speaking to so many people. What I'd like to do just in a couple of minutes is talk to you about a few areas that our team is working on in terms of how it works, then give you a highlight of, I think, an important few points. Of course, I'm happy to take questions at the end as planned. So the clinical team here in the headquarters of WHO really works within 4 areas. So an operational capability to respond and advise member states as required for case management cases for COVID-19. A responsibility to work with member states and our regional headquarters in terms of training to increase clinical capacity and management of patients with COVID-19, guideline development at the moment in an interim emergency guideline stage, and then lastly to coordinate the clinical research priorities for this disease. So if I cover a few of those areas in more detail. So firstly, I think many of your members, I'm sure, will be involved in a number of outbreaks in different settings in their medical and clinical experience. One thing that we're pretty passionate about, excuse me, in the clinical team is that we don't forget the importance of focusing on the patient. So sometimes with a number of different responses and pillars to the outbreak response in your countries, if we're not careful, especially given the scale of this problem, we sometimes forget the individual patient at the bottom of this. And actually, unless we continue to focus on the patient and deliver high quality care, the rest of the outbreak response really struggles. So that always has to be prioritized in terms of delivering the best possible care in all settings for patients with COVID-19. With that respect, at the moment we have out on our website, that's freely available, of course, technical guidance about how to look after patients, which is in a pretty straightforward format for COVID-19, both in the hospital setting, but also for those who aren't in the hospital setting, who are in other locations, so home-based care or in other facilities. I would add that given the rapid knowledge and acquisition of data in the last month since that first version was written, certainly for hospital-based care, we'll have version number 2, hopefully out next week. So in terms of a few key principles in terms of what you know about this disease, we've learned a lot from partners in China who've been sharing data with us and from all the publications that I'm sure many of your members have seen. It's clear there's quite a spectrum of severity of the disease, and we expect at least 80% of cases to be mild. The percentage then of severe and critical cases, and really when we say severe, we mean those cases that need oxygen, looks to be about 15 to 20%. We may have some more data from other countries like Republic of Korea that suggest even that rate is lower, which will certainly be helpful. And how you manage those groups is going to be challenging. When everyone thinks of treatment, and this has been a problem with viral hemorrhagic fever outbreaks or others in the past, people always think about the drug that we need. And clearly there's groups and individuals working on therapeutics, but I think it's a really important message that your members can give to your patients and communities, that actually for this condition, optimized supportive care and delivery of the basic things well will probably make the biggest difference. So actually, unless you can deliver oxygen safely to these patients, it doesn't matter what wonder drug you have that comes out of the clinical trials. So I think it's really important that messaging from your group back to your communities and patients to say is there is treatment available for this disease. It's standard supportive care in hospitals for those with severe disease. And I think at this point too, in this preparedness stage, we need to look at your local facilities in your communities to think, how are we going to practically deliver oxygen, which is probably the key drug that we need to deliver to patients with COVID-19, to potentially large numbers of patients. And I think innovative solutions are a way to look at this. In terms of the research agenda that we're trying to drive, so we still accept that we don't fully understand everything about this disease. So we call that the natural history of disease in terms of when people become more sick and which groups are the sickest. We know already that vulnerable populations appears to be those who are older, with significant case fatality rates above 70 years or 80 years, and those with other medical comorbidities. But we need to understand more about the disease, and also, as April has just mentioned, about transmission of virus, particularly around how long people remain infectious and when they shed virus. Because for us as healthcare workers, we need to understand that to protect ourselves and other patients who are in the health facilities too. So other research priorities that we're looking at, I would say that we're not focused on the requirement to ventilate huge numbers of patients in intensive care settings across the world. Where that can be delivered, that will undoubtedly save lives, but we have to think about settings, some of which you work in, where we don't have access to a high number of intensive care beds and critical care expertise. And so we're looking at interventions that maybe can stop people heading towards that intensive care or mechanical ventilation, such as high flow nasal oxygen. And so one of our research priorities is looking at the safety and the efficacy of that in the coming days or weeks. And that process has been going on for a month, to try and see how we could roll that out to all settings to try and reduce the mortality and morbidity of this disease. If I can just give a quick note to training before I finish. So a number of different groups and organizations are doing training on clinical management of COVID-19, and that's something that we'd obviously strongly encourage. Only last week, the head of our clinical team was in our African headquarters doing a train-the-trainer course where 20 different trainers came from different African states to have that training, and then we hope that will be cascaded down within the countries they return to. There's further training going on in Nairobi, in Senegal, in 2 weeks' time. That again has been coordinated by the African headquarters, where again we'll train the trainers in managing these cases, which we hope will then escalate down to all of you too. So I'm not going to say much more, as I think that's certainly 2 to 3 minutes, but of course we'll take questions with colleagues at the end.
Thank you, Tom. I'm now going to hand over to my colleague, Catherine Kane, who works for the Department of Health Workforce, and she's going to speak a little bit about health workforce considerations and facility preparedness in the context of this outbreak.
Hello, everyone. You may have heard yesterday and our Secretary General reiterated his focus on ensuring that those who are caring for others are cared for, and that there is a priority for ensuring that they do get the appropriate supplies. At the same time, he called for rational use of masks, gloves, gowns, etc. So we trust that you will be working with us to ensure that the right workers have the right equipment to do their jobs. Further on the health workforce standpoint, we do have a document available that Yvonne will talk about shortly on rights, rules, and responsibilities of health workers, which includes the access to protective equipment, but it also includes the importance of health workers having reasonable time for working, that they have access to health and mental health resources, that they have access to sick leave. Now, as general practitioners, you are always working, but it's important for you to remember and to access resources on mental health and psychosocial support, both for yourselves and for your extended teams who are delivering care in communities. I'd like to introduce you briefly to a package that we'll send right after this conference, which was developed by our colleagues in the Western Pacific, talking about facility health worker preparedness, and also deals with a few elements of dealing with the general public. The document includes materials that are very simple, so very easy to share with extended staff on preparing at the facility level. That's intended for healthcare facility management and intended to be shared at staff trainings and meetings. There's a second piece that is focused on managing patients, including triage and intake. So that should be shared with staff and be used in taking in patients and trying to establish separate areas within your facility for patients showing symptoms. There's a third product, which is focused on yourself from COVID-19, and that deals with the appropriate levels of personal protective equipment. It is at a simplified level, and for further reference, you'll want to look at the guidance that Dr. Baller spoke about earlier. Fourth piece of guidance is quite important, and it's some basic information about communicating with patients with suspected or confirmed coronavirus. As Tom emphasized, it's important to deliver respectful patient care, and as family doctors, you are at the forefront of ensuring that patients will come into your facility, will come seek your advice, and do know that they'll get care. So it's important when you talk with your staff about how to work with clients coming in. There is a fifth piece, which is just a general information piece about what we know about coronavirus. It is at a basic level that can be understood by anybody walking into a health facility, and it's a poster that can be posted that says, this is what it is, this is what we know about how it can be transmitted, and this is what you should do. The sixth element is discussing coping with stress. We have some extended resources on mental health and psychosocial support, and also a document on psychosocial first aid. It may be something that you can use community health workers to deliver within the community when talking to the broader public. And then the last one is basics on hand hygiene. Wash hands, wash hands, wash hands. So one of the major messages that we're getting from our technical colleagues is that hand washing is a basic line of defense, not to mention a basic health, public health measure that all of us can well appreciate. We'll send this set of material to you so that you can use it at facility level. And for each of these areas, there is more in-depth information for clinicians.
Thank you, Catherine. I think just to pick up quickly on a point that you just made in terms of sharing resources, I think we will be able to set up a mechanism by which we can distribute some of the resources we've been referring to today. Last but not least on our side, I'm going to hand over to Yvonne, who's going to talk about protection of the health workers' safety and occupational health.
Yeah. Good afternoon, everybody. Yes, the patients are very important, but also we need health workers to respond to this outbreak, and we need the health workers to remain healthy and safe during the whole outbreak and in good mood and not to suffer a lot from the outbreak. So for this reason, WHO has developed a document called Coronavirus Outbreak Rights, Roles, and Responsibilities of Health Workers, including key considerations for occupational safety and health, that we will circulate, that specifies that health workers also, including all of you as family doctors, do have a lot of rights in addition to your responsibilities for patient care, but you also have the right to be protected. But also I'm aware that as part of general practice, many of you may be also managers of your little clinics, family clinics, so you have also the responsibility as a manager to ensure the staff in your clinic and the people who you're responsible for, some of you may be responsible even for community health workers, that they remain healthy and safe, and the nurses and even the ambulance drivers, they remain healthy and safe. In addition to the general occupational health and safety, which in some of the African countries already they have national programs on occupational health of health workers. I'm aware of the programs, very nice programs of Kenya, Ghana, Togo, Tanzania, both the mainland and Zanzibar. There is also a program, very powerful program in South Africa, Botswana, other countries. So these programs, many of them, they have been actually provoked by previous emergencies. For example, Uganda, the Ebola outbreak, the meningitis outbreak in Togo. And these programs are intended to be rolled out to all health facilities. In every health facility, there should be a focal point responsible for occupational health to make sure that staff remains healthy and safe, that there is personal protective equipment, that people are trained, if necessary, ensure medical examinations, if necessary, ensure vaccinations, so that all remain healthy and safe. When there is an outbreak, one specific problem arises very often, and this is violence against health workers. And violence occurs quite a lot in the health sector. We have data that about 50% of health workers experience violence, both physical, psychological, or sexual harassment at the workplace. And when there is a social anxiety in the community, when there is, in general, violence in the community, it comes to the health sector, and particularly in the case of emergencies, when there is an overload of patients, there is a shortage of resources, there is social anxiety, it is, violence is increasing. In many countries, they have introduced special laws for protection of health workers from violence, where violence against health workers is considered a criminal event. And the Chinese also introduced such a law, but also at the level of health facilities, you can do a lot to prevent violence. First is to be aware about the different forms of violence, and to inform your colleagues and your staff about violence, and to encourage the early reporting of any cases of physical, psychological, and sexual violence and harassment and abuse at the workplace or in the commuting to the workplace, but also related to work. This will help relieve the problems from the victim of the violence, but also will help you to introduce a zero tolerance to violence in all health facilities. This is very important, and because many of you also are part of national associations, I highly encourage you to have a discussion with the ministries of health, with the policymakers, and insist that there is a due respect to the health workers and the workers in the health sector. Because if the society, if the media are criticizing the health workers, then that translates into violence, into slaps, into harassment in healthcare facilities. Thank you.
Thank you very much, Ivan. So I think we have some questions that have come through on the group chat. If you would like me to continue to go through these immediately, we can do that. I'm going to read out the questions just for the purpose that there may be some people on the line who've actually joined by phone and are not able to see the questions. Let me see.
We'll still help you, Sarah.
Okay. Do you want to address the questions and we answer, or would you like me to just go through the chat?
Where you find a question, you just ask. In case of an extra question, I can find as we go along. We'll help you along. Okay, great. Right. Let me see. Okay, how long does the virus survive? I think April answered that before she left. The next question that we have is the virus sensitive to UV exposure that seems to be within the equatorial regions of the planet? So I'm going to give that to Tom quickly to answer.
Yes, sir. So I would say that we're learning more about this virus, and that work in terms of looking at viral persistence is ongoing. So the virus will be susceptible to UV light, but I think there's a number of different conditions that increase or reduce its ability to live in terms of humidity, temperature, etc. But ultimately, the virus is only exposed if you're talking about microscopic, in terms of if you can't see it there on a surface, then access to ventilation and light will improve. However, if it's in a thickened bodily fluid or a respiratory secretion, then obviously that UV light may not penetrate it. So it sort of depends on the climatic conditions. But I think more evidence will emerge as laboratories that can do culture and can undertake those experiments are doing those as we speak.
Thanks, Tom. And perhaps leading on from that, there is a question with regards to the fact that some folks are considering that the virus might thrive better in the temperate regions than in the tropics. Is there any substantive evidence to this regard? So I think at the moment, I mean, I think there is no, we're still collecting evidence on the way. I think a lot of people have been questioning why we have not been seeing more cases in Africa, and part of the questioning has been around, is this because of the climate? I think the bottom line is we don't have enough evidence at this point to make a distinction or a clear statement on this. There is no evidence with other coronaviruses that it is, survives better in different climates. And so I think the evidence is still emerging around that. Right, the next question on... Carry on, sorry.
Okay, sorry, Sarah. There's a question on maternal to child transmission. Is it possible? What are the transmission rates in maternal to child? Yes, that was one
thank you for the question. There is no evidence yet, and this is still being investigated. I think there are some other questions here. Let me see. Where are we with research into this discovery of a cure for this infection? I can start with this. I'm aware that there are a number of clinical trials ongoing in China. Some of these are drawing towards a conclusion, but as yet we have no, there has been no approved treatment as yet. So Tom, I don't know if you want to say anything else on that.
So yeah, I think when people are talking about cure, they're talking about the therapeutics in terms of the drug treatments that we might use to improve survival. So currently in China, there's now up to 200 registered clinical trials that are ongoing. Obviously, as you've seen, China's new case numbers are dropping significantly too. Outside of China, a number of countries are also using drugs for compassionate use, particularly some drugs that some countries think are going to be effective. At the moment, WHO has undertaken a prioritization initially to identify a couple of drugs that should proceed towards clinical trials. Further work is ongoing within that space, within the therapeutic team here. In terms of the trials right now in China of the prioritized drugs, so Kaletra, which many of your doctors will know as an antiretroviral drug that has been repurposed for this, showed some potential activity from the SARS outbreak and in vitro activity. A trial
So Sarah, I see a question here about surgical face masks with two sides, a colored side and white side. There is an instruction on the internet about wearing the mask with the colored side outside if you don't have a flu or an RTI, but if you do have the flu or an RTI, then the white side should be worn outside. Is there any truth in this? That's the instructions about mask wearing.
Sorry, I think Sarah is actually being kicked out, so we have a problem.
Oh, admission.
Hello?
Hello.
Hi. I'm sorry, somehow we were on mute.
Hi, Sarah, welcome. Good.
So I would just like to say with regards to the...
Go for it, Sarah.
So with regards to the face masks, there is one correct way of wearing a face mask. Somebody keeps muting us. Hello, can you hear us?
Yes, we can hear you, Sarah.
Thank you.
Can you just repeat the question?
So the question was, the surgical face masks have two sides, a colored side and a white side. There is an instruction about wearing the mask with the colored side outside if you don't have a flu, and with the white outside if you do. Is there any truth to this? I think our basic advice is there is one correct way to wear a mask. And however, having said this, the mask, we're advising that masks are worn only by those people who are ill or a health worker, a person caring for an infected person. And so our advice for the general public is that there is no clear evidence that it protects a person who is already healthy from getting infected. So only if you're unwell are you advised to wear a face mask. I think there are a lot of questions coming through. Aware that we're, let me see, a lot of the questions may actually be answered in some of the frequently asked questions that we have available and some of the guidance that we will be able to share. So if we don't have time on this call to answer all of the questions, we can definitely direct you to all the resources that we have talked about. Which one? It's temperature. Okay, but perhaps at the moment we say there is a question: are temperature checks reliable to identify those infected by COVID-19? Some people can cheat by taking antipyretics to lower their temperatures.
Obviously, the disease has an incubation period, and therefore airport screening or entry point or exit point screening doesn't always work to pick up cases. But there is another important point to this. So if people remember case definitions that have been used in previous outbreaks, in the past, sometimes people were very keen to put a temperature mark on that. Say for Ebola at the very beginning, people might remember it was high fever, and people thought that you had to have a temperature above 38. As soon as we did some research at the beginning of the outbreak, it was clear that the majority of patients at diagnosis did not have a temperature above 37.5. That is the same for Lassa fever in West Africa and other hemorrhagic fevers and other viruses. The same is true for COVID-19. So if you're looking in your GP surgeries or in other partners to have an arbitrary cutoff to try and pick people up, you will miss a lot of cases. So some data from China that looks at a big spectrum of cases suggests that actually only 40% or just over 40% of cases have a temperature above 37.5 at diagnosis. A history of fever is very important, and people will often report that 80 to 90% of the time. But using a temperature cutoff to try and work out whether someone has this or not is unfortunately not a good way to proceed.
Thank you, Tom. There's also a question, is there a template for us to use in community clinics for uniformity of advice to community members in waiting rooms, libraries and schools and public places? So I believe on the chat, Catherine has just shared the Wipro package she was talking about, which has some downloadable graphics that can be used and translated. So this would be very useful in the community settings to be able to translate the guidance and the advice into local languages. WHO is also translating a lot of our documents, infographics that we're producing into the 6 UN languages, and can definitely provide editable versions where necessary in order to facilitate translation. Does chloroquine work on COVID-19?
Well, a specific question. That drug hasn't yet been prioritized for evaluation by the R&D team. This has really come from some in vitro data that suggested that chloroquine was active. What I think we must always have caution with in terms of the drug concentration for any drug that you can deliver in an in vitro setting to show that it hampers viral replication, sometimes it's much more challenging to get that drug concentration in human subjects. And so that is a potential concern about chloroquine and other drugs that whilst it might work in the lab, it may not work in clinical disease. And as I say, the group that are prioritizing all these drugs are obviously experts within that area from all over the world. And they will look at all that detail, all that data in detail, and provide recommendations about what should be evaluated.
Thank you, Tom. There's another question about a recent research in Japan showed that there was a patient who was reinfected. So how soon should recovered patients be discharged from the hospital, and what confirmation tests are being performed to ensure the viral load is not able to reinfect? Maybe Tom can talk to this, but I think initially the guidance is that a patient can be discharged from hospital following 2 consecutive negative tests, at least 24 hours apart.
With clinical recovery.
Yeah.
So yeah, clinical recovery of the patient, and then 2 negative PCR tests taken from the upper respiratory tract 24 hours apart is the guidance that the WHO supports and that most countries are implementing now. We are aware, obviously, of the isolated case reports, including the case of Japan, that then had a subsequent positive PCR result later. I think we have to be very careful about looking at isolated case reports until we know more detail and understanding the pattern of that. We also must be clear that whilst some patients then may have virus in their upper respiratory tract at a very low level after recovery, that may not be viable virus, and then if they're asymptomatic, they should not necessarily shed that virus too. So the presence of virus in the upper respiratory tract is not really the same as shedding virus when you're symptomatic. So I guess in conclusion, at the moment we support the WHO and most countries who are managing high numbers of cases with that position of 2 negative cases. We're looking at this as a priority question for research within the clinical department.
Thank you, Tom. How long after disinfecting a room for COVID-19 should you admit another patient? I think disinfection measures are...
This is probably a question for April, I think, who is our IP&C lead that is here. But I think they do have good guidance on this, and after the appropriate disinfection methodology has been applied, whatever that might be, depending on the room and the environment, the patient that's being managed there, then generally after that short period, the room is available for reuse. But I think that data is available through the WHO IP&C guidance and national guidelines too.
Right. Do we have healthy COVID-19 carriers?
So that is really about asymptomatic carriage. So the latest data from China suggests that there is a small percentage of 1% of patients who do have the presence of virus in the upper respiratory tract, but don't go on to develop symptoms. But that's a small percentage of the total number of cases. More data is emerging, particularly from Republic of Korea and other countries that are managing high caseloads about this. What we do know is that often people who are suggested to be asymptomatic, actually if you follow their history course, a lot of them then do go on to get mild or other symptoms, and so aren't really truly asymptomatic. So I think some data that actually really saw this morning from our technical lead suggested that of those people who are labelled as asymptomatic, actually over 75% of them, if you follow them, do go on to get mild or other symptoms, which sort of questions that initial label of asymptomatic.
Thank you. So we have a question about the origin of the virus. Is it zoonotic or lab generated? So I think it's very clear that this is a zoonotic virus. There are intense investigations underway in Wuhan to try and identify the source of the virus. There have been some initial findings that it may potentially be linked to bats, but this is not 100% confirmed. Normally with coronaviruses, there is an animal host, and at some point in time, there can be a spillover event when the virus infects a human. And this is certainly what happened in the case of COVID-19, an animal host and then a spillover event into humans. We have a question, does alcohol cure coronavirus? I presume this means alcohol used as a sanitizer, and as April mentioned, 70% alcohol can be used as a disinfectant. For surface disinfecting, yes. Just to lead on from that, the question below says, what is the appropriate disinfection methodology for health facilities? April mentioned that the 0.5%, it's an envelope virus, so simple disinfectants like 70% alcohol and 0.5% chlorine will work. There is no evidence that using these on your body will prevent infection at all. The safest way to prevent yourself being infected is to avoid close contact with somebody who is infected. Wash hands regularly with soap and water or hand sanitizer. I think, let me see, what have we missed? Screening at airports. I don't think we can speak to the specifics of how many people have been screened in Johannesburg Airport. I think screening has been implemented at a number of points of entry. It has traditionally not been thought of as a very effective way of finding positive cases, and it can potentially divert precious resources away from other preparedness activities. Having said that, when the initial cases were exported from China, the majority of them were picked up through airport screening. And so it has been effective to a certain extent in some countries. Programs in schools. Are there any programs in schools for preparedness? I think these are mostly handled at a national level. if they are, and would be an extension of the basic hand and respiratory hygiene guidance that is being shared. We're aware that our partners, UNICEF, are working on some guidance for COVID-19 in schools, and I believe that will be ready for publication within the next week or so. So again, that will be up on our website and can be accessed. Let me see.
Sarah, there's
Yes.
a question from Baba Aye, who asks, how do we ensure that the labor rights of health workers are ensured through collective bargaining and social dialogue between employers and government and health workers? I think Baba Aye was a bit late. Ivan talked about this, but he can share it again so that they do hear what is there for health workers' rights.
Now, all countries it's very important that these plans involve all government sectors, including the labor sector, and that there are agreements also for protection of health, safety, and the rights of workers. All workers, but in particular health workers who are the resource for the response to the outbreak.
Thank you.
Over.
Oh, thanks a lot. Sarah, you can take over. How regular do we change N95 masks?
How regularly do we change N95 masks?
So obviously wearing an N95 mask offers a higher level of protection that is only recommended by WHO when there is the risk of aerosol generating procedures. And there's a list of those that include intubation or cardiopulmonary resuscitation, and we also include at the moment delivery of high flow nasal oxygen to that level. So in terms of a frequency, I don't think that we actually recommend a per time, because it depends on the situation that you're wearing that N95 mask in. They should be single-use items in terms of once you enter into a care area, which might be an intensive care unit or somewhere else where there's an aerosol-based risk, you would wear that for the duration of your time and then take off that mask carefully, which is a key thing that people need to take off their personal protective equipment very carefully at the end of your time in there, along with the rest of your personal protective equipment. So that really depends on how long the individual is going to work inside that area.
Thank you, Tom. You want to say anything, Tom, to Baba Aye? Sorry, we're just reading the messages that are coming in.
Yeah.
Right.
I think most of the questions have been.
Yes. The trade unions are very important, and social dialogue also at the national level is extremely important. We do not want to see health workers going on strike like happened in Liberia and other countries when we had the Ebola outbreak. So therefore it is part of the preparedness and response to maintain social dialogue at the national level with the trade unions of the health workers, in the health workers themselves.
Someone is asking, can dust masks be used when surgical masks are not available?
I think our IPC expert April had to rush off to another meeting, and I'm afraid that we cannot accurately answer that question right now. So perhaps if you would like to field those questions through to us in an email, we can reply to them off the call. Please comment on dead body management. Are there infectious any special guidelines on handling of these bodies?
Again, I'm always nervous to answer a question as a clinician for an IP&C expert, and I would refer people, this is included within the WHO IP&C kind of guidelines, I think, in that sense. But I think we would, as you've heard from April before, the virus can persist for a period of time, and then we would therefore obviously encourage the use of standard precautions in terms of managing patients who unfortunately passed away with this disease, because there is the risk of fomite transmission, you know, from secretions on patients or from around their environment. So I think the same PPE precautions would apply, or personal protective equipment, sorry, precautions would apply when doing this. But as I say, the definitive document is available on the website. And it's been developed by a collection of, you know, IP&C expertise inside and outside WHO.
Thank you. Unfortunately, a number of us here at WHO we're rushing, as you can imagine, from meeting to meeting to meeting. So perhaps we can agree in terms of follow-up from this call. We can create a distribution list and share some of, I know Catherine's been very active sharing already some of the resources. Thank you, Catherine. And we do have a PowerPoint that gets sent out twice a week with updated information, information on the resources that are being produced, a little epidemiology update, and we can certainly share that with you going forward. And again, it's been a pleasure to be on this call.
Nashkuru sana.
Sorry. Thanks very much, Dr. Ivan, Sarah, and the whole team for having taken time to actually educate us. It's everyone is wondering what is happening around the world in terms of COVID-19, but today we've gotten some highlights. We hope that we can do this again and share more as the research evolves and various treatments are tried, so that we are able to understand what we are doing, and we are able to understand this new phenomena, and we are able to sort it out wherever we are in the world. I truly appreciate we have our president, Professor Shabir, with us. Maybe he has something to say. Prof. Shabir? I think Prof. Shabir left. Professor Shabir is from South Africa. We also have a number of family physicians in the group from all over Africa. We also have a group from Greece, the whole of Europe, a number of them, and the US and Asia, along with Australia. It's been a very informative session, and I believe all the team members who have attended today, along with all the doctors from all over, inclusive of Kenya, my county, Baringo. We are live from my rural location, that's Baringo, Eldama Ravine. It's a small town, but doing big things. And we truly appreciate what we have learned today. Kindly, someone is unmuted. Do please mute your mic so that we can be able to hear each other. So Sarah and Sue.
Yes, thank you. Thank you for the opportunity. Really happy to do this and to
Sorry, Sarah, you got muted.
Oh yeah. Thank you. I just said that thank you very much for giving us this opportunity, and we look forward to continuing to engage with you going forward.
Thank you. So Professor Shabir? I think Professor Shabir is back. He wants to share a bit more about primary healthcare in the region.
I really appreciate the work you've done, Joy. Thank you. Well, thank you to Joy, I think, for being able to set up this this webinar, and I think she's going to continue with support from the WONCA executive. I think just briefly, we're looking at being able to engage with WHO on this kind of webinar series. Apologies. This webinar actually had registered almost 500 people, but we only have a limited subscription to Zoom, so it allowed only 100. We'll certainly be looking at another avenue to make sure the clinician on, is an important project. I think that Joy has actually mentioned a few things, but I'd strongly urge everyone to go and have a look at the AfroPHC.org website. You'll find it on also on a link from my website, profmusa.com. But I think if you just Google AfroPHC, you should find it. But I think that is an important avenue to explore teamwork with not only family doctors that come together and are supported by WONCA executive, but also all the PHC team members, including people that are here. So thank you very much. We appreciate your attendance and enthusiasm. Your team. You've been very patient. I think you appreciate that we're struggling in Africa to be able to make things work. I hope that you'll be patient with us and the management of this webinar. So I hope we can work together going forward and actually improving the quality of this outreach to workers on the front line. 19th World Family Doctor Today is doctors on the front line, family doctors on the front line. And I think we are all team members on the front line. So thank you all for the wonderful work you're doing. And let's hope that this webinar contributes to you being supported at the front line and be able to provide for patients in the way we all seek to provide with great quality primary health care. Just to mention that please go to the WONCAAfrica.org website to be able to pick up on the recording of this. So to those who may not have picked up the entire webinar, you can actually get that on the website in a few days. So over to Joy. Thank you, Joy. You can continue and close.
Sorry, thank you, Professor Shabir. It's Sarah here. I apologize.
Thank you very much, Prof.
Hi, Joy.
Yes,
just very quickly.
Yes, Sarah, go ahead. I think a few comments in closing on this would be very good.
No closing comments really, but just to say that we do host a webinar weekly on a Tuesday, which is aimed at the health sector, and I will share the details of that call with Joy to distribute with your networks. Thank you.
Great.
Over.
Wonderful. Joy? Well, if Joy, I'm not sure if Joy's on the call or able to join us, but thank you all very much for attending, and we would really hope you keep in touch.
Yes, thank you very much. We truly appreciate to all the attendees. Yes. Thank you very much. We truly appreciate all those who have attended. We appreciate the offer to be able to host this, and this has been brought to you by Baringo County and WONCA Africa, and also we appreciate the WHO team that took time off their busy schedules to be able to present to us this awesome presentation. We'll share all these articles that have been shared by Sarah and her team, and we look forward to a more prepared team in Africa and beyond, so that when this strikes in your country, there is no fear exhibited. All that you'll be having is a more prepared team as we go forward. And we also do, at this point, we have learned quite a lot about COVID, but we also have lost so many colleagues to this illness because they have been at the front line. And I felt as we close, we should also take a moment of silence to remember our fallen colleagues who have been at the front line fighting COVID out in China. We really, really support you. Our president for WONCA World comes from China, and he would have loved to be here with us today, but could not make it. But we really, truly need to also remember those colleagues. So a moment of silence, and then we can close this meeting and be able to look forward for another meeting. So we begin a moment of silence. Thank you very much. We truly appreciate the time taken. We look forward to hosting you again on this platform on other educative materials. Thank you, Dr. Ivano and Sarah and the rest of the team. It's been a great honor to have you. Thank you, and we appreciate it. We'll log out in a few, and we'll share whatever has been shared. For those from Kenya, we'll soon be sending you your CPD points so that you can be able to update them within the CPD platform. Thank you. Ivan, anything?
Thank you. I think, Ivan, do you want to say anything? One last comment?
Well, thank you very much to everybody, and let's hope this outbreak will be soon over. But whatever we did in preparation for this outbreak, even though there are no cases, it will just remind us that we need to stay healthy and safe as health workers and continue to provide good quality of care and continue to provide measures for protection of our patients, for protection of ourselves, and to provide, again, good quality of care. Thank you very much.
Thank you.
Thank you. Goodbye from WHO.